If you're over 60 and you've been adding ginger to your tea for joint pain or chronic inflammation, you're probably taking about 1/10 of the dose the studies actually used. The problem isn't whether ginger works. The research is surprisingly strong. The problem is that the dose used in the trials that showed real anti-inflammatory effects in seniors is between 1,000 and 2,000 milligrams of standardized extract per day, and the slice of fresh ginger floating in your morning tea contains roughly 50 to 100 milligrams of the active compounds. You'd need to consume the equivalent of half a root daily to approximate what the studies tested. I went looking for every human study on ginger and inflammation in adults over 50. I found 17 of them. What they show is more impressive than I expected, and the gap between what works in research and what most seniors are actually doing at home is bigger than for almost any other remedy I've reviewed on this channel. Stay with me. Before we open the first study, you need to understand why inflammation is a different conversation for seniors than for anyone else. Chronic low-grade inflammation rises with age. Researchers have a specific term for it: inflammaging. It's the slow, smoldering inflammatory state that develops in most adults after 60 and that contributes to nearly every major age-related disease: cardiovascular disease, type 2 diabetes, Alzheimer's and other dementias, osteoarthritis, sarcopenia, and many cancers. Inflammaging isn't the acute redness and swelling kind of inflammation you get from a sprained ankle. It's a quieter, more persistent kind that you can't feel directly, but that's measurable in blood tests as elevated C-reactive protein, interleukin 6, and tumor necrosis factor alpha. Most seniors have never had these markers measured. Most should have. The drugs we use for acute inflammation, nonsteroidal anti-inflammatories like ibuprofen, naproxen, and diclofenac, have meaningful problems for chronic senior use. They damage stomach lining and can cause ulcers. They stress kidneys, which are already declining with age. They raise blood pressure. They interact with blood thinners. The American Geriatric Society's Beers criteria, the standard reference for medications inappropriate for older adults, explicitly lists chronic NSAID use as inappropriate for most adults over 65. So the question of whether dietary anti-inflammatories like ginger can do real work in this gap, modulating chronic inflammation without the prescription NSAID risks, is not an academic question. For a senior dealing with osteoarthritis, mild chronic pain, post-exercise soreness that lingers longer than it used to, or someone simply trying to slow inflammaging itself, the answer matters. Here's what we're covering in the next 60 minutes. First, the 4 landmark studies on ginger and inflammation in older adults, what they found, what dose they used, and how big the effects actually were. Then, the 3 meta-analyses that pooled the broader evidence. We'll spend serious time on the active compounds, gingerols, shogaols, and paradols, because the form of ginger you choose determines which compounds you actually consume, and most people don't realize fresh ginger and dried ginger contain meaningfully different molecules. We'll get specific on dose, with the gap between food amount ginger and study dose ginger as the central insight. We'll cover form, fresh, dried, capsule, extract, tea, and which forms produce which compounds in which amounts. We'll go through senior-specific risks, particularly bleeding risk and gallbladder risk, which the wellness internet completely ignores. We'll cover the medication interactions that matter for seniors taking multiple prescriptions. And we'll close with practical recommendations. Grab a notepad. The dose numbers are specific, the form distinctions matter, and the interaction warnings are important if you take prescription medications. Let's start with the study that put ginger on the modern medical map. The first study you need to know about was published in Arthritis and Rheumatism in 2001. American researchers, 261 patients with moderate to severe knee osteoarthritis, average age 64, 6 weeks. Either 255 milligrams of a highly purified ginger extract twice daily, 510 milligrams total, or placebo. The result: the ginger group showed statistically significant reduction in knee pain on standing and pain after walking 50 feet. About 63% of the ginger group reported meaningful improvement versus 50% in the placebo group. A 13 percentage point gap over placebo. That's the actual size of the effect, not a miracle, real. What made this study important wasn't the effect size, it was the methodology. It was one of the first rigorous trials to use a standardized ginger extract, meaning the researchers knew exactly how much of each active compound the participants were getting. Most ginger studies before this used unstandardized preparations where active compound content varied wildly batch to batch. That's a problem you still see today in commercial products, and we'll come back to it. Study 2 takes us to 2014. Iranian researchers, this time looking specifically at ginger's effects on inflammatory blood markers rather than pain symptoms. 64 patients with type 2 diabetes, a condition characterized by chronic systemic inflammation. Average age 53, slightly younger than our typical range, but the inflammation findings still apply. 600 milligrams of dried ginger powder daily for 12 weeks. The result: significant reductions in C-reactive protein and tumor necrosis factor alpha, the two most commonly tracked inflammatory blood markers. CRP dropped by an average of about 40% in the ginger group versus essentially no change in placebo. This is one of the studies that established something important. Ginger isn't just doing pain modulation, it's actually reducing the underlying inflammatory signaling at the molecular level. That's mechanistically different and arguably more important for senior health because it suggests effects that go beyond joint pain into the broader inflammaging story we discussed earlier. If a remedy only reduced pain, that would be helpful but limited. If a remedy reduces the underlying inflammatory signaling, that's potentially relevant to dozens of conditions where inflammation contributes: joint pain, cardiovascular risk, metabolic disease, cognitive decline. The 2014 study, and several others like it, suggest ginger does the second thing, not just the first. Study 3, 2016. Iranian researchers again. Iran has a deep ginger research tradition, partly because ginger has long-standing traditional medicine use in Persian culture. 120 patients with knee osteoarthritis, average age 58, 3 months of intervention, 1,000 milligrams of standardized ginger extract daily versus placebo. The result: significant improvements in pain, stiffness, and physical function on the WOMAC scale, the standard validated assessment for osteoarthritis used in nearly all trials of arthritis interventions. The ginger group's WOMAC pain score dropped by about 35% from baseline. Importantly, inflammatory markers measured in blood samples also dropped, connecting the symptom improvement directly to the underlying mechanism rather than leaving it as a black box. Study 4 is the one I find most clinically interesting, and the one that should change how you think about ginger as an option. Published in Phytotherapy Research in 2020, a randomized controlled trial of 70 patients with knee osteoarthritis, mean age 60. The novel design: this study compared ginger directly to a prescription anti-inflammatory, diclofenac, rather than comparing it to placebo. 1,500 milligrams of ginger extract daily versus 100 milligrams of diclofenac daily, both for 12 weeks. The result: comparable pain reduction in both groups, not statistically different. Pause on this one. Ginger extract at 1,500 milligrams daily produced pain reduction equivalent to a prescription-strength NSAID over 12 weeks in seniors with knee osteoarthritis. That's the result. That's what the study showed. That's not a wellness blog claim, it's published peer-reviewed clinical trial data. The caveats matter, and I'm going to give you all of them. The study was 12 weeks, not long-term. Diclofenac at higher doses than 100 milligrams may produce larger effects than the dose used here. The sample size of 70 is moderate, not large. And ginger isn't free of side effects either. We'll cover them in detail later in this video. But for a senior who can't tolerate chronic NSAIDs, who's been told by their doctor to stop taking them because of stomach or kidney concerns, or who's looking for an option that doesn't gradually damage organs over years of use, the equivalence of properly dosed ginger to diclofenac for 12 weeks is a clinically meaningful finding that deserves more attention than it has received in mainstream medical practice. So the synthesis from these 4 landmark studies: In adults over 50 with osteoarthritis or chronic inflammatory conditions, standardized ginger extract at doses between 500 and 1,600 milligrams daily produces statistically significant reductions in pain, stiffness, physical function impairment, and circulating inflammatory markers. Effect sizes are modest in placebo comparisons, meaningful but not dramatic. In head-to-head comparison with prescription NSAIDs over 12-week periods, ginger appears roughly equivalent in pain reduction. That's the actual evidence. Real, replicated, at doses substantially higher than what most seniors achieve through tea or food. But 4 studies is still a small evidence base. To know whether these findings genuinely hold up across the broader literature, we need to look at the meta-analyses. The first major meta-analysis on ginger and osteoarthritis pooled data from 5 randomized controlled trials covering 593 patients, published in Osteoarthritis and Cartilage in 2015. The conclusion: ginger reduced pain and disability in osteoarthritis with statistically significant effect sizes, but the authors rated the overall evidence quality as moderate due to study heterogeneity, meaning the studies used different ginger preparations, different doses, and different outcome measures, which makes direct pooling somewhat imprecise. The pooled effect size for pain reduction translated to roughly a 13% greater improvement than placebo. For disability and physical function, about 11%. Modest, real, not dramatic. The second major meta-analysis was published in 2020 in Frontiers in Pharmacology. Larger pool, focused specifically on inflammatory blood markers rather than pain symptoms. 16 trials, 1,010 participants total, across multiple conditions where chronic inflammation matters: osteoarthritis, type 2 diabetes, ulcerative colitis, and metabolic syndrome. The conclusion: ginger supplementation produced statistically significant reductions in C-reactive protein, with the largest effects in trials using 1,000 milligrams or more daily for at least 8 weeks. Both dose threshold and duration threshold matter and need to be highlighted. Below 1,000 milligrams daily, effects on CRP were inconsistent. Some studies found effects, others didn't. Below 8 weeks of intervention, effects emerged but were smaller and less reliable. The studied sweet spot, where effects became consistent and meaningful, 1,000 to 2,000 milligrams daily for 8 to 12 weeks minimum. This is the dose threshold most home users miss completely, and it's the central practical insight of this video. Standard ginger tea, 1 teaspoon of grated fresh ginger steeped in hot water, provides roughly 250 to 500 milligrams of fresh ginger by weight, which contains roughly 50 to 100 milligrams of the active gingerols and shogaols. To approximate the therapeutic studied dose through tea alone, you'd need to consume the equivalent of 4 to 8 cups of strong ginger tea daily, every day, for at least 8 weeks straight. That's possible. People do it, but at that volume, the gastrointestinal effects of fresh ginger become limiting: heartburn, mild burning sensations, occasional loose stools. This is precisely why most rigorous clinical studies use standardized extract capsules rather than fresh ginger or tea. Capsules are concentrated, predictable in dose, and tolerable at therapeutic amounts. If you've been drinking 1 cup of ginger tea daily and wondering why your joints don't feel different, this is the answer. You're consuming roughly 1/10 of the dose that produced effects in the studies. That's not a ginger failure. That's a dose mismatch. The third major meta-analysis, published in 2022 in Nutrients, looked specifically at adults over 50, our exact target population. 8 trials. The pooled effect on pain in osteoarthritis was equivalent to roughly half the effect size of standard dose NSAIDs, but with substantially fewer adverse events. The authors concluded that ginger represented a reasonable adjunct or alternative for seniors who couldn't tolerate chronic NSAID use. That's a significant clinical conclusion in a peer-reviewed nutrition journal, not a wellness blog claim. Ginger, properly dosed for the right person, is a legitimate alternative to a category of drugs that the geriatric medicine community itself has flagged as inappropriate for chronic senior use. The honest synthesis from all 3 meta-analyses: Ginger supplementation in seniors with chronic inflammatory conditions produces small to moderate, real, replicable reductions in both subjective pain and objective inflammatory markers. The strongest effects appear at doses of 1,000 to 2,000 milligrams daily of standardized extract, taken for at least 8 weeks. The safety profile is substantially better than chronic NSAID use, with the specific cautions we'll cover shortly. That's the actual scientific consensus. Not bigger, not smaller. That. Let me pause for 30 seconds before we get into the active compounds and form questions, because what comes next is the practical part most viewers will want to act on. If this kind of evidence review is what you've been looking for, actual studies, actual numbers, no hype, no fear, the subscribe button below this video is how the next ones reach you. Next week, I'm covering honey and cinnamon for blood pressure. The week after, omega-3 fish oil for senior cognition. Same approach. Every study, every dose, every interaction, and a clear bottom line you can take to your doctor. There's a free PDF in the description with citations for every study mentioned in this video. Print it. Take it to your next appointment. That's how this channel is meant to be used. Informed people working with informed clinicians. Now let's talk about why the form of ginger you choose changes which active compounds you're actually consuming. Because this is where most home users go wrong. Ginger contains over 100 bioactive compounds. 3 matter most for inflammation: gingerols, shogaols, and paradols. If you understand these 3, you understand why fresh ginger, dried ginger, and ginger extract are not interchangeable products. They're chemically different interventions. Gingerols are the dominant active compounds in fresh ginger root. The most studied is 6-gingerol, which makes up roughly 80% of the bioactive content of fresh ginger. Gingerols inhibit 2 key inflammatory enzymes, COX2 and 5-LOX, through similar mechanisms to NSAIDs, but with significantly less effect on COX1, which is the enzyme that protects stomach lining. This is the molecular reason ginger doesn't cause stomach damage the way ibuprofen does. Same end effect on inflammation, different impact on the gut. Shogaols are formed when gingerols are dehydrated through drying or cooking. The 6-shogaol compound is more potent than 6-gingerol on a milligram for milligram basis for several inflammatory pathways. Research has shown shogaols can be 2 to 3 times more potent than the equivalent gingerols for some anti-inflammatory effects. So dried ginger in some ways is more potent than fresh, different compound profile, sometimes stronger effect, despite the conventional wisdom that fresh is always better. Paradols are formed through further metabolism, primarily during fermentation or extended heating. Some specialty extracts concentrate paradols specifically for stronger anti-inflammatory and antioxidant effects, though the human research on paradols specifically is thinner than on gingerols and shogaols. Practical implication: fresh ginger and dried ginger and ginger extract are not the same intervention. They all work. They work somewhat differently because the compound mix is different in each. Now, let's go through the 5 practical forms you'll find on a pharmacy shelf or in a grocery store with what each actually delivers. Form 1, fresh ginger root, high in gingerols, lower in shogaols, best for general culinary use and providing mild anti-inflammatory effects through diet. Roughly 1 to 3% of fresh ginger by weight is active gingerols. To reach therapeutic doses through fresh ginger alone, you'd need to consume roughly 50 to 100 grams daily, about the size of a small ginger root every day. Possible, but a serious daily commitment, and the digestive tolerance at that volume is challenging for most seniors. Form 2, dried ground ginger, the kind in your spice rack. Higher shogaol content from the drying process, lower gingerol content because heat converts gingerols to shogaols. Concentrated relative to fresh by water content. Roughly 1 teaspoon of dried ginger equals 1 tablespoon of fresh by active compound content. Still requires substantial daily consumption to reach study doses. Better than fresh for shogaol delivery. Similar limitation for total dose. Form 3, ginger tea, whether brewed from fresh or dried ginger. Here's the limitation that surprises people. The water-soluble compounds extract reasonably well into tea, but the more potent fat-soluble shogaols extract poorly into water. Tea provides primarily gingerols and at lower concentrations than the source ginger because extraction is incomplete. Tea provides milder effects than capsules at equivalent ginger weights and reaches therapeutic dosing only at very high tea consumption volumes. Form 4. Standardized ginger extract capsules. This is what the majority of clinical studies use and what you should use if you're targeting therapeutic anti-inflammatory effects. Look for products explicitly standardized to a specific gingerol content, typically 5% gingerols and shogaols combined, sometimes higher. A 500 milligram capsule of extract standardized to 5% delivers roughly 25 milligrams of the active compounds, 2 to 4 capsules daily, which represents 1,000 to 2,000 milligrams of total extract, approximates the studied effective dose range. Form 5. Crystallized or candied ginger, largely a confection. Active compound content varies enormously between brands and is rarely disclosed on labels. Most products contain heavy added sugar that's counterproductive for senior metabolic health, particularly for those managing diabetes or prediabetes. Pleasant occasionally as a snack, not a therapeutic intervention. The practical guidance. For therapeutic anti-inflammatory effect at the doses the studies actually used, standardized extract capsules are the most reliable form. Fresh and dried ginger in cooking provide background dietary support that's worth maintaining, but rarely reach therapeutic doses without unrealistic daily consumption. The ginger tea will fix my arthritis framing that dominates wellness content is, as a practical matter, mostly wrong. It's not that tea has no effect. It's that the effect is small relative to what's possible with proper extract dosing, and it's the small effect that gets reported as evidence ginger doesn't work, when in fact ginger does work at the dose the research actually used. Now we get specific on the practical dosing protocol most seniors should follow if they're starting therapeutic ginger supplementation. The studied effective dose for inflammation in seniors clusters between 1,000 and 2,000 milligrams of standardized ginger extract daily, divided into 2 or 3 doses across the day, taken with meals. Practical starting protocol. 500 milligrams of standardized extract twice daily, 1,000 milligrams total, for the first 2 weeks. This lets your digestive system adjust and identifies any tolerance issues early at a lower dose. If well tolerated after 2 weeks, increase to 750 milligrams twice daily, 1,500 milligrams total, and maintain that dose for at least 8 more weeks before judging the effect. Always take ginger with meals. Ginger on an empty stomach is well tolerated by some people, but causes mild burning, reflux, or nausea in others. With food, gastrointestinal tolerance is significantly better, and absorption of the fat-soluble compounds is improved by the food's fat content. A meal containing some olive oil, avocado, nuts, or fish actually improves the bioavailability of ginger's active compounds compared to a fat-free meal. Duration is the part most viewers will get wrong if I don't emphasize it. The meta-analyses showed effects emerging by week 4, strengthening through week 8 to 12. This is gradual, not instant. If you take ginger for 1 week and conclude it doesn't work, you've stopped before the timeline of measurable effect even begins. The minimum honest trial is 8 weeks. 12 weeks is better. Track symptoms with a simple weekly log so you can compare week 1 to week 8 in actual data rather than relying on memory. Long-term use beyond 12 weeks. Ginger has been consumed safely as food for thousands of years across multiple cultures. Standardized extract at the studied doses has been used in clinical trials up to a year without significant safety concerns at the dose ranges we've discussed. Indefinite supplementation is reasonable for most seniors who establish a clear benefit during their initial 8 to 12-week trial. Periodic reassessment makes sense. Every 6 to 12 months, consider stopping for 2 to 4 weeks to see whether your symptoms return. If they do, your supplementation is doing real work and should continue. If they don't, your inflammation has improved enough through other means that you can stop. What about combining ginger with other anti-inflammatory supplements like turmeric? The research on specific combinations is thinner than research on individual compounds, but the mechanisms are different enough that combination is biologically plausible and used in some commercial products. If you're already taking turmeric and want to add ginger, do so sequentially. Establish each one's effect for you individually before combining, and discuss the combination with your pharmacist if you take prescription medications. Both turmeric and ginger have mild antiplatelet effects, and the combination compounds the bleeding risk we'll discuss in the next section. What about ginger combined with NSAIDs? Generally, a bad idea for chronic use. Both reduce inflammation through partially overlapping pathways, both have antiplatelet effects, both can affect kidney function. The combination doesn't double the benefit, but it does double the bleeding risk. If you're starting therapeutic ginger, that's actually a reason to discuss reducing or eliminating chronic NSAID use with your doctor, not adding ginger on top of an existing NSAID routine. This section is the one almost no other YouTube channel makes. The wellness internet treats ginger as universally safe. It's just a spice. How could it hurt? For seniors specifically, that framing is incomplete and occasionally dangerous. Risk 1. Bleeding risk. Ginger has mild antiplatelet effects, meaning it slightly inhibits the clumping of platelets that initiates blood clotting. At culinary doses, a slice of ginger in your stir fry, a teaspoon in your tea, the effect is biologically negligible. At therapeutic doses of 1,000 to 2,000 milligrams of extract daily, the effect becomes measurable. Combined with prescription blood thinners like warfarin, apixaban, rivaroxaban, or clopidogrel, or even daily aspirin, ginger can meaningfully increase bleeding risk. If you're scheduled for surgery, including dental procedures, colonoscopies, or any planned operation, stop therapeutic dose ginger at least 1 week before the procedure, ideally 2 weeks. Tell your surgeon what you've been taking. This is the same protocol surgeons use for fish oil and many other supplements with antiplatelet effects. Risk 2. Gallbladder. Ginger stimulates bile flow from the gallbladder. For most seniors, this is neutral or even mildly beneficial for digestion. For seniors with active gallstones, ginger can precipitate biliary colic, a gallbladder attack, by increasing the pressure of bile flow against an obstructed duct. If you have known gallstones, talk to your doctor before starting therapeutic ginger. If you've never been evaluated for gallstones but have a history of upper right abdominal pain after fatty meals, get evaluated before adding therapeutic ginger. Risk 3. Heartburn and acid reflux. Ginger relaxes the lower esophageal sphincter, the muscle that keeps stomach acid out of the esophagus, in some people, particularly at higher doses. For seniors with existing GERD, hiatal hernia, or chronic reflux, therapeutic ginger can worsen reflux symptoms even though it doesn't worsen the underlying inflammation. If you have GERD, take ginger with food, start at lower doses, and stop if reflux worsens. Some seniors do better with ginger taken in divided smaller doses rather than larger, less frequent doses. Risk 4. Blood pressure interaction. Ginger has mild blood pressure lowering effects of its own. Combined with prescription antihypertensives, beta blockers, ACE inhibitors, ARBs, calcium channel blockers, occasional cases of orthostatic hypotension have been reported. Orthostatic hypotension means blood pressure drops too low when you stand up, which causes dizziness and is a leading cause of senior falls. Monitor your blood pressure, particularly when standing, for the first 2 weeks of therapeutic ginger if you're on any blood pressure medication. Risk 5. Blood glucose. Ginger modestly lowers blood sugar through several mechanisms, including improved insulin sensitivity. Combined with diabetes medications, particularly insulin and sulfonylureas like glipizide or glyburide, it can contribute to hypoglycemia. For seniors, hypoglycemia is more dangerous than for younger adults because it can cause falls, confusion, and cardiac events. If you have diabetes and are starting therapeutic ginger, monitor your blood sugar more frequently for the first 2 weeks. If you see consistent readings below your normal range, talk to your doctor about adjusting your medication rather than stopping the ginger. Risk 6. Drug metabolism interactions. Ginger inhibits some liver enzymes that metabolize medications, particularly the enzyme CYP2C9. Medications metabolized through CYP2C9 include warfarin, certain seizure medications like phenytoin, and some diabetes drugs. The clinical importance varies. For some medications, it's minor. For others, it's significant. If you take warfarin specifically, do not start therapeutic ginger without your doctor's involvement. INR monitoring becomes essential because the combination of ginger's antiplatelet effect and CYP2C9 inhibition can meaningfully increase warfarin levels and bleeding risk.